Welcome, and thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. Thank you to Acceleron, Bristol Myers Squibb, Gamida Cell, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. David Sallman. Dr. Sallman is an assistant member in the Department of Malignant Hematology at Moffitt Cancer Center in Tampa, Florida. Dr. Sallman's clinical interests are myelodysplastic syndromes, acute myeloid leukemia, and myeloproliferative neoplasms. Dr. Sallman earned his MD degree from the University of South Florida College of Medicine. He completed an internal medicine residency at Massachusetts General Hospital and most recently a hematology oncology fellowship at Moffitt Cancer Center. His research interests focus on the development of novel targeted therapeutic strategies for phase 1 and phase 2 clinical trials for patients with myelodysplastic syndromes and acute myeloid leukemia based on the underlying mutational drivers of each disease. With that said, it is my pleasure to introduce Dr. Sallman.
Thank you for the introduction. It's really a pleasure to be here today and really hope that the session will definitely be educational, but really look forward to the sort of question and answer session where really we could discuss any facet of therapy and sort of the MDS and AML space. These are my disclosures. And this is really a broad overlook on the objectives. Of course, we will look at CAR T therapy, but we're really at our infancy in patients, predominantly for myelodysplastic syndrome, a little bit farther advanced in acute myeloid leukemia, but clearly these diseases are a spectrum. And so I'm also going to focus on key objectives to think about when we're thinking about novel IO therapy for patients with MDS and AML, and then potentially extrapolate some from some highly active and encouraging therapies in the space and whether or not they may actually ultimately be able to be transformed into a potentially CAR T target. We'll talk about some of the pitfalls, some of the real challenges that we have in patients with myeloid malignancies, which is really quite different than if we think of B-cell malignancies, including myeloma, lymphoma, acute lymphoblastic leukemia. They have really an optimal initial target to go after, and we don't in our case. And then there's maybe some other intrinsic issues and sort of the bone marrow of these patients that may be significant challenges. So real quickly, just to frame, who we're kind of talking about, the focus of this talk is on MDS and AML, but really if we're thinking about higher risk MDS patients, I would define that really as intermediate or higher. Clearly the IPSSR is the most commonly utilized system now. But I think importantly is that if you look at high, very high, really no question that they're a high risk group of patients. But what about the intermediate risk? And so we've looked at clinical models. This is a collaboration with MD Anderson. So if you're older, if you have circulating peripheral blood blast, if you're transfusion dependent, we could end up creating a score where we can quite nicely stratify the intermediate risk group. And so potentially, again, if you're a higher risk intermediate patient, we may think about very similar therapies as any other higher risk patient. Actually, many high risk MDS trials across the world right now do include the intermediate risk group, although leave it a little bit up to the physician on, do they think the patient is really right for this type of trial versus a lower risk type of trial. So this is one model. Some have used an IPSS score of 3.5, of greater than 3.5 to recognize more of a higher risk subtype. And I think most importantly, and this is something that's going to really bear out hopefully in its sort of final model over the next couple of years, is to come up with an optimal molecular model. So this has been developed in myelofibrosis and some other blood cancers, but we have a lot of data over the past decade looking at the impact of mutations. So if you look at these circles, the size of the circle represents how frequent of a mutation. So clearly mutations in epigenetic or splicing are the most common type of mutations. Whereas targetable mutations, such as things that we could potentially utilize, pill or targeted therapy for, are actually quite rare in MDS. And when we look at all of the mutations together, really these genes have borne out as either good or bad. I think really clear, and I try to bold this here, is that SF3B1 in the absence of an adverse risk mutation is clearly a good prognosis, a much more indolent course, low risk to develop acute myeloid leukemia, where there's no question that P53 really represents the toughest and most challenging mutation from a prognosis. I think very clear overall that EZH2 is also adverse. And then these other genes overall have been more often associated with adverse, but I think, again, the goal of an international working group, molecular committee, is to utilize both retrospective data on over 5,000 patients and prospective data on over 1,000 patients, and really give a much more personalized prognosis. So it won't be, hey, this simple, 5 categories. Hopefully we will have a very personalized approach. And this may, again, dictate some patients may be more needing of higher risk type therapies, whereas other patients may be okay with lower risk therapy. So this is coming and may shape a little bit when we're talking about what is higher risk MDS. And then when we think about our disease, so a lot of times we think about looking under the microscope, how many cells are blasts, and if we get it less than 5, that's great. And when we think about an AML and many other hematologic malignancies, though, however, and this is data in AML, just having a morphologic remission, which would be the gray, is not really that great. Unfortunately, there's still many leukemia cells still there, and the vast majority of time, these will ultimately lead to a relapse. And I'll show a little bit of data on that in a moment. So can we target that group of patients? Can we convert a quote unquote MRD positive patient and make them an MRD negative patient, which is really the best and optimal remission? And I really think both and high-risk MDS and AML will really be one of those very key biomarkers to know really what therapy is working best and really to define what the prognosis of a patient after they go through a therapy. So I think achieving that, and although that has been predominantly in AML, I'll show the MDS data that exists, I do think as our therapies improve, and especially when we think about cellular therapies like CAR T, this is really critical. And so why is that? So this is, again, data from AML, and it's pretty nice. It actually used 2 systems to define MRD. One, and I would say what's historically been considered more the gold standard, is MFC, which is multi-parameter flow cytometry. So this looks at a lot of different targets on the outside of blast to define what a leukemia cell is. But its cutoff is typically about 0.1%. And then they also used a NGS or next-gen sequencing platform, which looks at a host of genes, often in the around 40 gene category, and often we'll get to about this 0.1%. And you can see if you achieved negativity with either test, which is the blue or the green and the orange curves, that was better than being positive for both. But clearly the best and the lowest chance to relapse is if you achieve negativity for both. And so maybe a combinatorial approach may be key. In general, particularly for MDS, flow cytometry has not been validated, and we can identify mutations in nearly all patients. So I do think, particularly when we think about MRD for MDS patients, that deep sequencing, error-corrected sequencing, again, to at least get to 0.1%, if not using other sequencing technologies such as duplex sequencing, which can maybe get you closer to 1 in a million. I think we're going to really then be able to define how good of a molecular response are we having to therapy. And I think that's going to be of great importance, because maybe using CAR T and other novel cellular therapies is not the right approach if there's like overt relapse, but maybe optimal when there's very low levels of disease. This just kind of show you some data on how relevant this can be. This looks at outcomes to myeloablative transplant in patients that have AML, and these data have been shown in MDS as well, and I'll show that in a moment. But you can see myeloablative actually could potentially overcome MRD positive patients, or at least some data sets have shown that. But you can see in this data set, if you had MRD positivity, your outcomes were actually identical as if you had active leukemia or more than 5% blast, which is kind of hard to imagine, but that's really the case. Whereas patients that had MRD negative disease, you can see that their long-term probability of likely being cured may approach that 70 percentile range. So again, very meaningful response, especially when we're thinking about curative therapeutic options, particularly when we're thinking about transplant. So what about some data in MDS? So this is data we put together. This is not looking at traditional MRD. This is just using standard next-gen sequencing platform. Most have cutoffs between 2 and 5%. So a decent level of remission, but not something that's 0.1% or greater. And you can see in the survival curves that patients that were positive for any mutation had significantly worse outcomes. And in curve B, if they were negative at the last check, you could see almost that whole group of patients, was still alive long term. And we correlate that with response, I think not unexpected, and why we consider a true complete remission in MDS to be the most valuable response is that most patients that had a true CR cleared their mutations. And you can see that there are 2 dots, a purple and an orange dot, and maybe slightly colorblind in the CR group that were positive when they were in remission. And for what it's worth, both of those patients actually relapsed. So really a good snapshot into how good of a response your patients have. Whereas in patients that had no response to therapy, you could see mutations were dictated at all. And when we looked at a multivariate analysis, we're incorporating a lot of different features. What treatment did they get? What was their mutation status? What was their IPSSR risk? Where did they go to transplant? You could see clearance of all mutations was very, very relevant to predict for improved outcomes. And when we focus on P53, it's even potentially even more true. So I really feel for P53 mutant patients, ideally clearing that mutation is a really important outcome to achieve in the setting of the treatment. And you can see patients that had expanded to greater than 20% at any time had worse outcomes. Looking at it another way, if you achieved negativity, again, this is not MRD, but just less than 5%, you could see the outcomes were significantly better. And again, when we looked at all the different factors together, it was still valuable looking at the clearance of the P53 mutation. And so when we think about transplant, again, back to those other data, P53 has been the one mutation in all transplant data sets to predict for poor outcomes, with some centers even questioning whether or not transplant should be utilized. Although if you look at long-term data, about 20% of patients are alive long-term, but our goal is, of course, to really greatly improve that number. So when we looked at all patients that get standard of care hypomethylating agent therapy alone, you could see on the left, if they cleared their P53 and went to transplant, they had significantly improved survival. I think longer follow-up is needed, and the data set is overall on the small side. But if you look on the right curves, if a patient did not clear their P53 and went to transplant, other than one patient, there was no, difference in HMA therapy alone. And so potentially looking at the molecular level of response may help choose what is the right option for a patient on should they or should they not go to transplant. So here's some actual MRD data. This is really the only MRD data that exists in reference to transplant. And this again used both a targeted sequencing panel as well as a error-corrected sequencing panel, and both show the same thing. And really what it shows is that if you had persistent mutations, and this is that red curve that looks poor, and you went to a reduced intensity transplant, that the outcomes were very quite poor, with many patients relapsing. Whereas if you had a myeloablative transplant, or you were, quote unquote MRD negative, those patients did better. I think this needs to be refined a little bit. How much does myeloablative versus reduced intensity matter in this setting, I think is a question. We know that reduced intensity is an amazing option for many patients that, let's say, are older than 60 with clearly better outcomes than, let's say, HMA therapy alone. These were data that were presented at ASH last year and published in JCO recently. But all it's showing that, again, I think achieving a high depth of remission, ideally with new therapies, I think is a really important, part. And what about specific to CAR T? So I think this is one of the most impressive survival curves. So this looks at a CD19 CAR used in ALL patients. And they looked at what was the outcome if a patient had just relapsed disease, more than 5% leukemia blast, again, ALL, versus patients that had less than 5% blast. And you can see the patients that had that low disease burden potentially are being cured by their CAR T therapy. And although responses clearly happen irrespective of this, that the high disease burden group, many of those patients relapsed, and actually most of them, if not all, relapsed in less than 2 years. So potentially treating a patient with a CAR T at the right time is a really important factor. Of course, we have to get our CAR T for MDS and AML patients, and we're going to talk about that. But again, I think ideally down the future, maybe treating patients at the exact right time is very relevant to really get the best longer term outcomes. And when we think about, well, maybe what other challenges that we have. So a lot of groups have been looking at this, and there are a host of problems. If you look at the leukemia cells itself, some of these tumor cells express markers that turn off the immune system, such as PD-L1, or have other factors that are immunosuppressive against the T cells, which are a predominant adaptive immune cell. There are also some enriched bad immune cells that actually suppress our immune system. And actually, a lot of work's been done by our group and others looking at particularly MDSC, or myeloid-derived suppressor cells. These can be very negative on the immune function of MDS patients, and a lot of therapies are focused on potentially eradicating those. Also, adverse T regulatory populations. Again, anything that turns off your killer T cell in the setting of cancer, such as AML and MDS, can be a major problem. So what about the target? So we kind of mentioned even right off the bat that when we think about B-cell malignancies, they have CD19, they have BCMA, these targets that are really expressed on all the leukemia cells and actually don't have a lot of critical normal function. In AML, and a lot of the work is in AML, but some have shown overlap with MDS. The challenge is that when we look at some of the major targets, and I would say for a bulk target, CD33 and CD123 have been the two main targets. These are just antigens on the outside of the cancer cells, is that they do have expression on normal stem cells, and so our ability to make blood. So if you look at the top curve, you could see that mice that, and this is shown in the figure on the left, mice that get the CAR T had their disease eradicated, had better survival. But if you look at the bottom curves, what this is showing is normal stem cells. You can see in both of these papers that the mice essentially had all of their stem cells eradicated. And thus, because of this, there's been concern if you use a 33 or 123 CAR that you may just wipe out blood cell production. And thus, at this point, really all patients that are getting CAR T for MDS or AML really are thought to, basically need to be ready to go to transplant if this happens. Now, whether or not in humans this really occurs, meaning that maybe expression is lower on healthy cells and that you really don't wipe out normal stem cells, I think is a great question. We'll talk about some data, as we go in some other concepts, maybe as a workaround. But this was some of the concerns. So this has limited some of the patient population that can ultimately go to CAR T. But again, whether or not this is truly a requirement or not, I think we're going to have to learn over time. And this looks a little bit in more detail. So this looks at some common targets, again, CD33, CD123. CLL1 is probably the third biggest target right now. And basically what the group was showing, so you could see expression in the blast or the leukemic stem cell, which is sort of this red or maroon color, is high in a lot of these different antigens, so good target from that perspective. But again, if you look at the green, these are normal stem cells. You can see that there is expression with 33 and 123, but maybe lower with something like CLL1. So is that potentially a more specific target? And then what the data on the bottom are showing is, well, if you choose more than one together, CD33 TIM3, CLL1 TIM3, then maybe the expression comes quite exclusive to the leukemia stem cells. So from a safety perspective, if you chose that, I'm going to show that in well, maybe I'll just jump to the next slide. So when we think about these things together, and if you ask my hypothesis for the future, I really do think that likely we're going to have to target more than one antigen. And so several groups have looked at this. And so as an example, if you looked at CD33 and CD70, greater than 97% of the AML samples expressed one of these, while less than 5% of normal expressed, the combination. And so then there's really two thoughts, and these are the picture at the bottom. One is what we would call a combinatorial CAR, which means that you can see as two, it's basically two separate CARs. So it will get activated if it recognizes either target A, target B, doesn't matter what the target is. And so the really good part about this is, unfortunately, in leukemia stem cells, in blast populations, that you may have 70% express one marker and maybe 30% don't express it. And so if you only kill 70%, that's clearly not good enough. And so this is what we call antigen escape. So to get better killing and to get a better chance of remission, this approach is probably better. Now, on the other side, if let's say safety is the bigger issue, and you only want to eliminate cells that have both targets, you could make a CAR, and then its second signal for go or killing of what we call a costimulatory receptor. So again, you would require both for this cell to then become active. The good part, again, is this would likely be extremely selective against the tumor cell and spare normal tissue. Again, I think as of right now, efficacy is really the major thing we need, more so than the safety of it. And because ideally, we're going to get deep remissions that last a long time. So I do like the thought of targeting more than one antigen with the combinatorial approach, but we're still learning the safety and the data and the outcomes for single antigen CAR. And hopefully these data are going to become more apparent over the next year. So let's now move into some of the targets. Again, so 123 is one major target. And again, it's expressed in almost all AML cases, although I would say data at some centers has been somewhat heterogeneous. So maybe on the very low level of expression in some patient populations. Clearly, it's also been shown to be overexpressed in MDS. And so there are several what we call bispecific agents, which means on one side of an antibody, they target what you're targeting, in this case, CD23. And on the other side, they recruit your T cells, which are essentially all CD33. So it basically brings your immune system in contact with the tumor cell. And so we'll talk about a couple of agents. This is XmAb 14045. And these data were last presented at ASH by Dr. Ravandi. And, not to get into the details, they look at a lot of different dosing strategies with bispecifics. They can also cause a lot of the safety issues of cytokine release syndrome, of infusion reactions, and particularly with CD123 targeting, you can get sort of a swelling issue or a shortness of breath issue that we call capillary leak syndrome. So they're looking at a lot of different approaches for that. And going along with that, again, CRS, or the cytokine release syndrome, which is typically fevers in the setting of other symptoms as well, is pretty common, but a serious event, or what we would call grade 3 or higher, was only in 8%. Some liver inflammation, which is common with these type of therapies, was reversible. And significant like neuro side effects of being confused or seizures or anything like that was extremely rare. I think, we're always excited about any type of response, and you can see response rate did happen, although on the lower side of 15%, but other patients having some benefit. And you can see here, you can see this in the waterfall plots. I think one of the negatives of it is if you look at the x-axis on the bottom, that the response rate, even in good responding patients, which you would say are the sort of neon and darker green, is that a lot, some of these patients, the response, a lot of it was quite short-lived, really other than 2 patients, one of which who went to transplant. The responses were all done within less than 4 months. And these therapies, if you're in the hospital for several weeks, at least during the first cycles, and to only have a couple month response, I think that's a big negative. Again, some proof of concept that targeting 123 does have activity, but a challenge is how can we make this better? One big thought again is, are we using it in the wrong setting? So instead of using it with gross disease, could we, say, hey, low level MRD positivity, is that the best patient to target? The other thing that they saw in this data set was a low blast percentage. And so maybe giving time for these therapies to work. And that would actually make MDS a really good group of patients to think about, because the blast burden is lower. It's extremely rare to become proliferative unless things change to AML, and thus may have more chance for response. Another bispecific agent farther along is flotetuzumab. It's what we call a DART. You'll hear bites at darts. And so they had several publications in 2020, and really, yes, responses happened, but they wanted to see, could they try and predict those responses? And so clinically, if patients were what we call primary, refractory, meaning that they kind of fail straight up the standard chemo, this group seemed to be enriched for response. And when they did a RNA sequencing profile, they had this sort of immune infiltrated signature, and I'll show this in some detail now on the subsequent slide. And so patients that had this immune infiltrating, you think if they're infiltrated, maybe you can unlock them, with therapies such as bispecific agents or other immunotherapies. That was clearly the best predictor, again, smaller subsets. And what they saw in this data was that a lot of these patients were P53, which goes along with these patients failing traditional chemo. And so especially in relapse refractory P53 patients, there are no standard options and actually very limited options even in clinical trials. So maybe this is a group of patients that would be great to think about in this disease. Again, how long these responses are lasting is a big question, but maybe we can get some patients to transplant. Again, we're always looking for responses as well as potentially predictors of this. In this trial, this agent is ongoing in larger studies now, particularly in some of the sort of primary refractory patient populations. And we know also, again, this is a little bit more data from the same group looking at P53. So again, they see better responses. They see this immune infiltrated signature in this P53 mutant patients, although they do see some adverse features such as PD-L1, if you look on the bottom right, being upregulated. So although maybe immune infiltrated, they actually may be like an immune adverse patient. And so we may need to think multifactorial when we're thinking about targeting P53 patients. And so we've really looked at this in detail. The data on the left really shows that PD-L1, which is a negative factor, so this blocks your immune system response. These cells were significantly upregulated in P53 mutant MDS and AML patients versus wild type. And also, if we look at adverse immune cell populations, such as the Tregs, and we actually looked at these sort of highly immunosuppressive Tregs that have an activation marker called ICOS, and they don't have an inhibitory receptor called Treg, these were also enriched in our patients. And when we looked at the percentages, so if you had more than the median number of these Treg populations, it actually predicted for poor survival. Some of this may be contingent on the fact that a lot of these patients were P53 mutant. And so thinking about, well, why is PD-L1 upregulated in these patients? There's been several known regulators. One is MYC. And so if you look at figure C, what this shows that is as MYC goes up, the amount of this negative or inhibitory receptor on the leukemic stem cell went directly up. And then another known regulator is a microRNA. So microRNAs can shut down expression of targets or can be, such as PD-L1. And so actually in this case, having less microRNA could be bad. And actually when we looked at a very broad microRNA panel, the only microRNA to be downregulated was miR34A, which again is a known negative regulator of PD-L1. So thus there's two reasons why patients that have P53 mutant could have higher PD-L1. And in a nice collaboration with Dr. Ebert's group, they basically created these cell lines where one cell line is a leukemia cell, and then they add a P53 mutation. So the only difference between the cell line is a P53. And thus this really validated our data nicely. You can see in mutant versus wild type that clearly MYC is increased and miR34 is completely wiped out. And ultimately we showed that this led to the PD-L1. So we really give a mechanism for this as well. So although targeting PD-L1 with, let's say, traditional immune therapy such as nivolumab, pembrolizumab, atezolizumab, has not really shown a lot of excitement in myeloid malignancies, maybe in these subset of patients or in combination with other therapies like CAR T, maybe that could be an important thing to test in patients with P53. And can we give some functional proof of this? So this is some nice work with Dr. Daver and Dr. Andreoff at the MD Anderson Cancer Center, where they looked with a single cell cytokine assay. Basically says how functional are your T cells. And essentially, if you were mutant, you had very dysfunctional T cells, even if you were never treated. We know for a long time, the more relapsed a patient is, the more dysfunctional a T cell may become. But for P53, it was kind of bad all the time. So I think that goes along with the data we just presented. I think the other thing this highlights is that, again, maybe in more upfront treatment, is that the better time to think about CAR T therapy? So could we take out your T cells before you ever get your first treatment, go through the treatment, and then if there's disease left behind or the treatment doesn't respond, then use those cells, to ideally get a response. So what about CAR T? What's the actual data, when we think about, some of these targets? So I think I'll start with what I would consider maybe the most exciting data. This is a data out of China with a CAR that, again, targets more than one antigen, CD33, CLL1, and not a ton of patients. And this trial has taken a long time, but out of the 9 patients, 7 out of these 9 patients achieved a very deep remission. You can see MRD negative. And 6 of those patients went to transplant. Some of these were young kids, and although some were adults. They were very refractory. They had a lot of disease. And so I think any responses are great, but having 7 out of 9 with a great response is very exciting. And notably, one of the 2 non-responding patients was negative for one of the targets for CLL1, kind of giving proof that the target matters. So this CAR is ongoing. I'm really excited to see further data. But again, since this has had the highest percentage response, granted very low numbers, I think we need to think about that as some of these other single antigen CARs are going forward. One CAR that we've been involved with is PRGN-3006, and it's kind of a unique system. So most CARs, you take out the cells, and you then have to grow them outside of the patient, often for 3 weeks and sometimes longer. So that could be a long time to wait in patients that have relapsed myeloid diseases. So this uses actually a non-viral system called a Sleeping Beauty plasmid. And so essentially you can put multiple genes into that plasmid. You then make them go into the T cells. And this happens very quickly. So actually from taking them out to giving them back to the patient, we can do this in really 2 days. And so this CAR has a target for CD33. It also has like an internal food supply, which is membrane-bound IL-15. And then in case these cells are growing wild or there's a lot of toxicity, it has a kill switch. So we can eliminate these quite rapidly if required. This is just the preclinical data. I won't go into too much detail, but clearly the CAR can eliminate leukemia in these murine AML models. And importantly, does show that the addition of the membrane-bound IL-15 allows these cells to last without giving them cytokines, which can have toxicity if you're utilizing those in patients. And so we've now had for a while open clinical trial, and this one is one of the only ones in the world right now that does allow actually both MDS as well as CMML patients. Again, with the caveat that you have to be able to go to transplant. And we have 2 cohorts. So one cohort, you basically take the cells out and you give them back 2 days later without chemo. But all other CARs that have been approved in other diseases have required lymphodepletion so that the cells can really expand optimally. And so we have another more traditional arm where you do get fludarabine and cyclophosphamide chemotherapy. And this trial is ongoing and look forward to giving more presentations as we go. We sort of had a single anecdote at the first ASH presentation of a patient where their blast went down and they still had CAR cells present at 6 months. So again, very early data, but look forward to looking at this further, but it really presents a novel design. And then again, well, if let's say 33 is the best target, but the problem is, do we wipe out normal cells? Again, this has not been proven in humans, but we know that this happens in mice. And so this is some work out of Sargil's lab at the University of Pennsylvania. And there's a couple of companies looking at this as well, can you take a patient, and what this showed is that you can knock out CD33 in a stem cell and it does not hurt the function, meaning that it's not required for our normal blood cell production is essentially what this showed. And so what the concept really is, at least with Dr. Gill's concept, is basically you would take your donor, so your healthy donors could be sibling or unrelated, and you basically make 2 products. One is you make a CAR T that will attack CD33. So this would be using normal T cells, right? This is from a normal donor, so that may have its advantages. And then you also make the rescue product in the back end, which is going to be stem cells that don't have any CD33 expression. And so you take your patient and you ultimately do a transplant. And then, when these cells are engrafted and have taken over the bone marrow, you then give the CAR to eradicate any 33 disease. Again, this would bypass the safety issue of targeting CD33. It may allow for long-term persistence of the cells. I think the big negative is, well, what happens if your leukemia cell doesn't express CD33, or there's a subpopulation that then grows out? You've gone through all of this then to have, a CD33 negative leukemia. So I think that's one of the big challenges, but I think it is a novel concept looking at a way, can we create a more leukemia-specific antigen, and at least preclinically, it's possible. Now going to, there are lots of bispecific agents. You can see, that the overall response rates has been very low, typically in that sort of 10% realm. And again, we don't have great identifiers for who is the best responding patient. A lot of these drugs are still ongoing. And again, maybe part of the key is, again, lower blast, maybe MDS patients. Also, CD33 is highly expressed on those myeloid-derived suppressor cells. So again, right patient, right time, all of this matters. Again, some proof that targeting 33 matters, but we have a ways to go to really think about approval. This just really summarizes that also wiping out the MDSC is important. So again, potentially that one of the challenges is the T cells in a patient with MDS and AML may be very beat up. And so using an off-the-shelf product, it has some significant, potential benefit. One of the problems, though, is you have to then modify the T cell that it doesn't attack all of somebody's normal cells. And so this is one concept of UCART123. So it's a 123 CAR that it activates its T cell receptor so that it can't hurt your normal cells. And it also knocks out CD52. So one challenge with the off-the-shelf approaches is that you may have to really suppress a patient's immune system a lot so the CAR cells don't get rapidly eliminated. And so alemtuzumab, which is a therapy that can target CD52, we may be able to use that, get better immune suppression, and then make these therapies work well. But it does also make a patient at higher risk of infection. So this just again shows preclinically that UCART did improve overall survival. And there's an ongoing phase 1 trial that we're a part of as well that is ongoing. We'll have to see what the data show on subsequent presentations. And then lastly, again, CLO1, I think, is the one other real major single antigen CAR. There's lots of other possibilities out there, but CLO1 is one that, again, is a little bit more specific to AML than the HSCs. And so that may make it potentially a better target. There's been a couple of anecdotes, a single case report published this past year with a 4th generation CAR against CLL1, and a patient had a durable CR out about 10 months. And then in a pediatric AML trial just presented in abstract form, 3 out of 3 AML patients had a response. And so there is KITE-222, which is has a CD28 co-stim, so kind of similar to the CD19 to Selenoglutell CAR T therapy, where again it targets CLL1. And so this is the sort of phase 1 design of the study. Will be a 3+3, and this is just entering the clinical trial domain. So we'll have to look for future presentations. I think what level of CLL1 is required. This is not you can't be like, well, do I have CLL1 expression? This is not built in any standard flow cytometry assay. So we may do this by staining or immunohistochemistry, or this may need to be built out. But I think thinking about what is the companion diagnostic? Is there a certain level of CLL1? Let's say if 30% of people respond, but if you have high expression, it's everybody. Well, then maybe we can choose what patients that may be optimally chosen for good response to this therapy. And so really with just the last couple of minutes, I just want to swing into, well, what other targets are out there that are looking exciting for what, let's say, immune myeloid therapy? Again, may not be able to be incorporated to CAR T, maybe adjuncts to CAR T therapy. Again, we talked about this a little bit earlier, but our traditional therapies have been very underwhelming. Again, maybe subsets like P53, maybe different combinations. So there's still a lot of studies that are ongoing, but not a clear path forward for sort of the traditional immune checkpoints. And so I'm going to just focus on a couple of novel ones that we and others have been a part of. So one is CD47. So CD47 is actually expressed on most of our cells, and it actually tells our innate immune system or macrophages and dendritic cells to not eat me. So a don't eat me signal. I like to explain this like Pac-Man. It basically turns Pac-Man off, but if you can block this pathway, it can turn Pac-Man on. And so it's definitely a normal mechanism to protect a lot of our normal cells. But when we think of cancer cells, and this is specific to AML, but it's also been shown in MDS, that the leukemia stem cells and bulk blasts have much higher CD47, and a higher expression is associated with inferior outcomes. Again, very similar data in REEB MDS, and also with higher risk versus lower risk patients. And thus, this may be a critical balance. And so targeting this, what we call CD47 SIRP alpha pathway, and there are multiple ways to be able to do that, may increase phagocytosis, may also turn on your T cells. Basically, you can get more antigen presentation to your T cells, turn them on. Some of these agents may also be able to directly kill the tumor cell as well. And so the agent that I would say is most far advanced in myeloid malignancies is magrolimab, which is a first-in-class IgG4 monoclonal antibody that targets CD47. And you can really see with the cancer cells in green and macrophages in orange, really no phagocytosis. But as soon as you add magrolimab, you then get this rapid induction. You can see these orange cells have now engulfed multiple green cells. And the way we think we can get selective elimination of cancer cells is that almost all of our normal cells don't express a pro-eat me signal. So if you don't have a please eat me, it won't happen. So it doesn't matter if you block CD47, our normal cells are okay, but if you're a cancer cell, you then get rapidly engulfed. There's one notable exception, and that is old red blood cells, and I'll talk about that in a moment. So when we utilize it by itself, it has not worked that great, but with azacitidine can increase that pro-eat me signal, calreticulin being the main one. So you see with azacitidine, the expression goes up. And in an aggressive AML xenograft model, that both, if you did AZA with magrolimab, that was much better than either therapy alone, ultimately improving the survival of the mice. And so these are the data. This is the last update from the MDS group, which was 33 patients, but most patients have responded with a complete remission rate about double than what we would expect with single agent hypomethylating agent, and almost all patients having blast reduction. So quite encouraging data. And then when we think about that bad group, the P53 subset, this is focused on the AML data last presented at ASH 2020. You can see, again, a high response rate, a more deep response than we would expect. And I think as encouraging as anything is when we look at the survival. Well, P53 AML typically has a survival around 6 months. And although this is not earth-shattering, having a survival now of 13 months or doubling is quite remarkable. So again, encouraging data, what the exact mechanism for why magrolimab may work better in P53, if that's really a true tenant, or if it's really, if this is a group that just doesn't respond to standard agents, including agents like hypomethylating agent with venetoclax, as far as long-term outcomes, is this a new therapy? And so there are registrational trials with this, both for all higher risk MDS patients, as well as specific in P53 and AML versus HMA venetoclax in that setting. And magrolimab, there may be multiple other ways to think about it. So any drug that may increase the pro-eat me signal, this includes venetoclax itself, combination cytotoxic chemo, other antibodies. There may be a lot of different ways to augment this. And so because of that, there are a lot of ongoing trials. There are triplet trials in AML. There may be triplet trials in the future for MDS. Could we combine these with a traditional immune checkpoint, use both of them together? Could we combine them with more P53 specific therapies, such as eprinetopop or APR-246, or there's a second generation of APR-548? I think that would be a very exciting option in P53 mutant MDS and AML patients. And then what about other, some of the therapies we'll talk about in a moment? And so there could even be CAR T cells. I think it's a little bit more of a challenge with CD47 because it is widely expressed. So you'd have to come up with a way to make it selective against the leukemia cell, but lots of trials, lots of exciting therapies, and really a hot target in patients with myeloid disease. The other main one to focus on is TIM3. And so TIM3 kind of has a dual negative MOA. So one is it helps the leukemia stem cell to survive. It actually makes its own food supply, allows these leukemia cells to self-propagate. And at the other end, can also turn off the immune cell. So as a negative or an immune checkpoint. It may also impact phagocytosis as well. And so there's a TIM3 targeted agent called sabatolimab in combination with hypomethylating agents, similar to the design of magrolimab studies. And overall, it's been well tolerated. We don't see a lot of severe immune-related toxicities. You do see in 24%, but only about 5% had grade 3, and some of these were really just transaminitis. So better tolerated than your traditional immune checkpoints, not a high degree of pneumonitis or colitis, which I think is encouraging. And has had higher response rates. I think the true complete remission rate has not appeared to be that dramatically different than single agent HMA. But I think with these type of therapies, really the durability of the responses is really what is most important. And so I think about the future directions, I think we need to think about what drugs or combinations may give optimal synergy. When patients progress, why are they progressing? And can we incorporate multiple novel strategies together? We talked about really important thinking of not just as one disease, but as molecular cohorts. I like to think of P53 yes, no as a major distinction given the differential outcomes. And then can we incorporate MRD likely by high sensitivity sequencing, duplex sequencing? I do think sequencing, particularly for MDS patients, will likely be the MRD test of choice in the future. And so these are all really critical items. I'm going to skip over CD70, although we can save it for the discussions time in a minute. And really with that, I'd like to think of a number of great collaborators, both at my center on some of the CAR T work that you saw in particular, and my funding sources, particularly from the MDS Foundation and the Dresner Foundation, as well as support in some of the studies by the MDS Clinical Research Consortium. And so with that, I really look forward to the question and answer part. Really open to any question in relation to higher risk MDS, particularly focused on immune therapy. So thank you for listening today.
Thank you, Dr. Sallman, for your wonderful presentation. And thank you all for joining us today. For those who haven't sent in your questions, you can start submitting your questions in the chat box found on the bottom menu bar. And for those who want to revisit this recorded webinar, a viewing link will be sent to all registrants and will be available on the MDS Foundation website for on-demand viewing within 10 business days. All right, let's proceed to the live Q&A. Our first question comes from Fred. He has MDS with the TET2 mutation, and he wants to know if this mutation caused his MDS, and can CAR T be used to eliminate this gene?
Yeah, so I think it's a good question. So I think we do know that mutations obviously are the cause of MDS, but with some genes it's a little bit complicated. So we know that there's a spectrum of mutations in the blood and bone marrow called clonal hematopoiesis, and typically you'll hear terms called CHIP, clonal hematopoiesis of indeterminate potential, or ARCH, age-related clonal hematopoiesis. Both essentially mean as we get older, and when we say older, typically over the age of 60, more and more patients will ultimately have mutations in genes. So if we look at everybody in the world, 60, 65 or older, 10 to 15% of patients walking on Earth have a mutation in their blood and bone marrow. And the three most common genes are what we call DTA. D is DMT3A, T is TET2, and the A is ASXL1. And usually these mutations are at low levels, typically a percentage or a variant allele frequency of less than 10%. They're often by themselves. And by definition, a patient has to have normal blood counts. And if they had a bone marrow, would have a normal bone marrow. And then there's sort of this whole spectrum in that if you have a low blood count and you have a mutation, but the bone marrow is normal, you have what we call CICUS, which basically means you have a clonal cytopenia. So you have a mutation and a low blood count, but the US of undetermined significance, and then ultimately MDS. And so this is a whole spectrum. And so I think what's really critical, although mutational analysis needs to be done in all patients being evaluated for MDS or who've been diagnosed with MDS, it is a spectrum, and having a mutation alone by itself does not ultimately make a diagnosis. Now, TET2 is one of the most common mutations, again, in CHIP or in ultimately in MDS. It doesn't really have a good or bad prognosis. We and others have showed that maybe those patients do better to hypomethylating agents, but it's kind of, again, it's a common mutation, but it's not always directly concordant with disease and can be in sort of pre-disease states as well. I think as far as the question can we when we're talking about immune therapy, the real hope is that this would be agnostic to mutation. So if we're targeting the outside of these tumor cells, ideally it doesn't matter. You could have mutation A, B, C, D, X, and it would make not a hill of beans of difference. So for example, if we go to CAR T and again, myeloma or in lymphoma, again, there's been no, it's not like it's only for patients with X mutation, and mutations happen in all these other cancers as well. So I don't think that there would likely be, quote unquote, a TET2 specific CAR T therapy. But that being said, I think in the immune cells that are in patients, is there something different about the cancer cells based on the mutation? I showed a lot of work on the TP53 mutation. And so we may continue to learn. So maybe patients with mutation A, B, and C may better respond to a certain therapy or not. And I think right now we really need to get to having a therapy. But then as we go, these are, all patients have been sequenced. And so again, if there's a subset of patients that do best, and more work is coming out. So there's a couple of other inhibitors in MDS, for example, an IRAK4 inhibitor, where they're seeing responses in splicing mutations, which is one of the other most common groups of mutations. So with any therapy, I think it matters. But for immune therapy, cellular therapy, the hope is it would be irrespective of what type of mutation.
Thank you, Dr. Sallman. The next question comes from Christy, whose 69-year-old father was diagnosed in 2018 with high-risk MDS with a complex karyotype with 7 to 8% blasts and 8 mutations. He participated in a clinical trial for 19 months, but unfortunately his MDS transformed into AML in March of 2020, and unfortunately he passed away in 6 months in September of 2020. She wants to know if MDS is always considered terminal. Does MDS ever present as a chronic style disease like diabetes that requires management where a patient can achieve a normal life expectancy?
Yeah, it's a good question. Of course, sorry for the loss of your father. And this just really highlights actually a pretty typical scenario, I would say, in high risk. So MDS is a big spectrum. So if you are low risk, for example, an SF3B1, maybe asymptomatic patient, many of those patients may ultimately live their normal life expectancy, especially when you think the median age of diagnosis is in the upper 60s, like your father. So there is a spectrum of very indolent disease. Now, for high-risk patients, the vast majority, and I would say probably 90 to 95%, will have symptoms and require therapy. And, the outcomes, especially, let's say, in a complex karyotype MDS, range with the survival of 12 to 18 months. That's really where we're at with standard of care therapy, such as, hypomethylating agents. And what happens, especially if you progress, to AML, it's not as much just the fact that now you're AML. I get this all the time in clinic. There's nothing really magical. There's a high degree of overlap between MDS and AML. But the problem is, especially in older patients, let's say greater than 75 or younger with other medical problems, is you're out of a lot of options. So, we have Vidasa, venetoclax, or Dacogen, venetoclax in AML. But once you've already been exposed to Vidasa, the response rates are lower. And then there are mutations like P53 where response rates are lower. And so a lot of it is a lack of therapeutic options. And we don't typically, although sometimes you can pick them up at the time of AML, have mutations we can target, with pills. So I think a couple of things that this really highlights. One of the most important things that I would emphasize is for first-line treatment of high risk, really, if at all possible, patients should ideally go on a clinical trial. And there are, right now, 3 large phase 3 trials ongoing where we need to definitively prove that the combination works better than Vidasa by itself. And then we can work to even further improve that. There's already triplet trials. So there is azacitidine with venetoclax, there's azacitidine with magrolimab, there's azacitidine with sabatolimab, and there's actually a more targeted therapy for patients that have activation of what's called PML-RARA, where it's for a subset, but there's also a phase 3 trial in that setting. And again, there will be 3 drug trials where, again, it's always going to be with typically azacitidine plus 2 other drugs. But it really is important because we need to improve the long-term prognoses of these patients. At the same time, what's really critical is if patients are, fit enough, and for me, if they're less than 75 and don't have severe other medical problems, patients need to go to transplant. I mean, very clear data that's now been published in JCO this past year and presented at ASH of last year, that in older patients with high-risk MDS, the long-term survival is remarkably different if you go to transplant versus not. Now, at the same time, I think getting in the very best remission before you go is extremely critical. We showed some of that data today, but I think this is going to continue to evolve. So I think one of the important secondary endpoints in these studies is when we look at the patients that go to transplant, how well do they do? Because I think our goal is to cure these patients, for them to have their normal life expectancy. But it's very complicated. It's a challenging course along the way. There's a lot of ifs, thens, and things like that. But I think it just emphasizes a number of these goals. And again, our goal is to cure patients of their disease. If we could get them to transplant, think about maintenance options afterwards. Obviously, our goal is also quality of life the whole time, but it's a very good question.
Thank you, Dr. Sallman. Great answer. Now, the next question kind of relates to what you just answered in the previous question. This question is from a bone marrow transplant survivor who had a match but an unrelated donor, and they want to know if CAR T can be used for them.
Yeah, so clearly, in a patient that has a relapse after transplant, there's technically no standard of care therapy. And if you're an MDS patient, the vast majority of patients would have already had hypomethylating agents. So for CAR T world, a lot of patients, going on these studies are post-allo transplant patients because they have a lack of options. Now, most of the trials, and I kind of emphasize this some of the presentation, have been historically for AML. And a lot of times when MDS patients do progress, especially after transplant, they progress sort of into an AML state. So there's, again, a lot of overlap. But I think these CAR T trials definitely need to be utilized for, transplant patients who have MDS. For example, our, PRGN CD33 CAR does allow patients that have MDS. And the one good thing about MDS is the lower blast count probably means lower toxicity. It allows time for these therapies to work. And again, there's no standard of care option. I think the transplant challenges, and this is not specific to MDS, but for MDS and AML, is that when a patient relapses, they may be a mix of their own cells versus their donor cells. So you hear, what is called chimerism. And so if we're making a CAR from your cells, that could be a mixed population. And so that can have its own challenges. If you're arming the donor cells, there could be some graft versus host disease risk. But on the other side, maybe those donor cells are a little bit healthier than the patient's, cells that are sort of part of the disease process. So there can be benefits and risks. You do have to be off immunosuppressive therapy, and a lot of times trials may require you to be off for 6 weeks because those drugs would blunt the potential for benefit from the CAR T cells. But that creates a big challenge of waiting, of graft versus host disease popping up as you're getting off of those medications. But there's no question that, post-allo relapse, we really need new therapies. And this would be one of the more exciting therapies from my perspective to consider in that setting. Again, assuming your patients are off immune suppressive therapy, don't have graft versus host disease, and again, are otherwise in a decent shape. The other thing, and now, this may not be for all therapies. Again, we talked a lot about CAR, but there are other cellular therapies, gamma delta T cells, NK cells, TCR gene. Again, the point is lots of different cell type therapies we can use, and then some CAR Ts may not be applicable. But currently, if for 33 and 123 concepts, a lot require that you have a donor. So if you've already relapsed, you have to theoretically be considered for a second transplant, which is very high risk. So that complicates things in an elderly high risk MDS patient population. But I have treated MDS patients up into the 80s with CAR T cell therapy in the past. This was with the NKG2D CAR. But we don't like to use age as a cutoff. You do have to be fit right now. You have to be often considered transplant eligible. Of course, my 85-year-old was not, but yes, definitely should be considered.
Thank you, Dr. Sallman. This is a little bit related, but instead of coming from a post-transplant patient, this question is from Keith, who is moving towards transplant following hypomethylating agent therapy as a bridge to transplant. And he wants to know what patients, if any, can benefit from CAR T therapy.
Yeah. No, I think, the patient audience must be probably a lot of experts, in here. So these are really, really good questions. So I think, one of the most, if I say what's the most important metric we're looking at achieving, let's say over the next 5 years, is we know the better remission that you're in pre-transplant. I showed a little bit of data with this, the better your chance of being cured. And of course, that's the goal when we take patients to transplant. There's nothing more I think, aggravating and frustrating to all of us as we go through all of these things. And then the patient has a disease come back at 3 months, 6 months, 12 months. And there's no question, again, the better the remission, the analogy I like to use is this iceberg analogy. And so, historically, we could see the top of the iceberg. But now with better and better technologies, and this could be next-gen sequencing, duplex sequencing, PCR, flow. And again, I think I talked about a little bit in the presentation that I really like the sequencing part, is now I can look at deeper and deeper under the water, what amount of disease is better. And so if I can eradicate that, there's no question in my mind that a patient will then have a better outcome to transplant. So I do think in the years to come, and not specific, could be CAR T, could be some of these other cellular therapies, could be some of these other targeted agents. Can we have a patient that goes on azacitidine, decitabine? Now, those therapies extremely unlikely to eliminate mutations to low levels, but maybe more so with some of these combinations, like that we talked about, again, like magrolimab, venetoclax, sabatolimab. I think, more and more data need to come out, but we've shown some of that, for example, with P53. And we know that if you clear P53, that's the group that has the potential to benefit from transplant, whereas if you don't, largely it's not the case. But yeah, I would love, if I had an approved CAR T cell therapy, then there's no question that's one of the most important groups to test. So you do a test with a bone marrow, let's say after 4 cycles of HMA plus whatever. And if you're positive, then you go on a trial with the goal of making it negative before transplant. Some of these concepts are up and coming. A lot of them are right now more AML focused, but I don't really like that. And I think a lot of times MDS is just as good to test it in. So I think it's a really critical question, both for CAR T, other cellular therapies, other new therapies. Again, if you have patients with positive disease, let's get them on a trial and ideally eradicate it before. The one big negative of that is that, of course, if patients can be cured with transplant even if they have some low-level disease. And so if you delay too much, and could you progress and relapse before you ever get there? So that's kind of the give and take. I think as therapies get more exciting, then those trials become more interesting. I think for right now, you can already make a strong argument for very high-risk patient populations. So, example, P53 with mutation. I mean, you saw our data and some other data that very, very unlikely to be cured by transplant. And so there's no question for me is either having a concept of a trial before transplant, or there are several trials ongoing. We have some at our center as well, again, with gamma T cells. There's a therapy called MT401. Again, these are not CAR T, but it's about thinking about these high-risk patients and using the therapy potentially after transplant as well, where maybe you look at the day 30 bone marrow, or maybe you just plan to give a therapy based on high-risk disease before transplant. So I think for high-risk groups, again, like P53, doing anything that's out of the box in the setting of allo transplant with the goal of improving the chances of being cured, I think are great ideas. And there's a lot of great ideas across the country trying to look at this, although we're very early and there's not sort of a clear, front runner therapy from my perspective.
Thank you, Dr. Sallman. The next question comes from Derek. He has the RUNX1 gene mutation. And after 11 months on azacitidine and then in Inqovi, his counts crashed and now he has no neutrophils. He wants to know where he can go from here.
Yeah, so great question. Obviously, we're not giving any extremely specific, recommendation, but sort of broadly. I think the question brings up a couple of important points. So again, we have extreme limited options. We have no new approval of a high-risk MDS therapy since the 2006 timeframe. Now, yes, oral decitabine, cesazuridine, which is in Inqovi, has been approved, but it's the same thing as decitabine. There's no difference. So sort of some helpful patient convenience factors and others, but it's not a new drug. And the challenge is if you get azacitidine and then you start to lose a response, or you get decitabine and start to lose response, switching to the other one in the vast, vast majority of cases is useless. So response rates have been as low as 5%. And we have extremely high volumes. I can think of one patient off the top of my head that we switched and had a really great response to the other one. So it's very, if you have nothing else, patients, do we consider transitioning HMA? We do, but it's very, very not likely to be effective. So to me, the lowest hanging fruit and I'm very biased, but the lowest hanging fruit in all of blood cancers is if you have failed azacitidine or decitabine, what we call HMA failure, that this is the group of patients that most needs clinical trials, more so than anything else. I think frontline is extremely important. Some of these subsets are extremely important. But if you fail HMA therapy, there is nothing. And so really the key for any patient, and this is per NCCN guidelines as well, if you failed an azacitidine or decitabine agent, that a clinical trial should be, strongly considered, because there's nothing else out there and there's nothing that is going to work in that setting. Now, if somebody has low blasts, they may just be able to go to transplant. It's always a consideration. But if blasts are high or they're not eligible or they don't want to go or can't go, in all those settings, essentially transplant is critical. And I think, part of the problem is a lot of the therapies that look exciting in the first line setting, so azacitidine or decitabine plus all that we discussed about, we don't know if they could work in the salvage setting. And so, I like, trials that are, don't have a hypomethylating agent in the salvage setting, because once you're resistant, you may still be resistant. Now, there are some options, for sometimes addition of venetoclax. We've published a paper in Blood Advances with the Sloan Kettering group, where we've had some patients who failed standard hypomethylating agent, where we're able to add venetoclax, but it is very myelosuppressive, so blood counts can be very low. There's a lot of challenges in managing it, but outside the box, clinical trial strongly preferred venetoclax, since off-label usage can be done in the setting of MDS, can be an option as well in some of these settings.
Thank you. The next question comes from a patient who has MDS with ring sideroblasts. They also have the somatic mutation of TP53 with 12% VAF, diagnosed in March of 2021. They would have been low risk if not for the TP53, and they just completed 4 rounds of Dacogen leading up to a possible stem cell transplant. Is CAR T therapy a realistic option?
So I think the one thing I'd like to highlight, and I don't remember if I don't think I had time to do this in the beginning. Actually, this is a strong correlation with P53. So we actually have presented data, and we have a paper ongoing where patients that have P53 actually very frequently have increased ring sideroblast. And so clearly there's a low risk subtype where patients have ring sideroblast and SF3B1. That's the best MDS subtype to have. But particularly if patients have excess blast, even 5% or higher, P53 actually becomes the most common mutation. Why I emphasize it is that I think in the community, at least across the United States, sequencing panels sometimes can take 3 weeks, 4 weeks, and sometimes say, hey, you got high risk, you got to start on therapy tomorrow. That's not right. We have time to await for sequencing because, again, for a lot of patients, they strongly need, not just P53, but all high risk, I would argue should be evaluated for clinical trial. Of course, that's not always possible. But anything that's a potential predictor of P53, that's the group that most needs to be considered. Again, important for all, but for P53. And so I think the 3 major things to think about, if patients have ring sideroblast on bone marrow with excess blast, we've extremely high correlation. We validated that with a Mass General, MD Anderson, and a group in the GFM in France. If you have a history, of course, of other chemo or radiation for past cancers, sometimes you could do just what's called P53 immunohistochemistry. Some labs do it, and actually, what we know is once you have a mutation, you get this accumulation of misfolded protein, and you can see that. We've advocated that should be considered in the evaluation of bone marrows. But I think the important is to identify it so that new therapies can be considered. As far as the subsequent question, I think we kind of discussed it already. I think anything that could be considered to eradicate disease, if it was, obviously P53 targeted, great. There's some, ongoing trials with APR 246 and hopefully APR 548, although not for MRD eradication, but could that be in the future? But if there was a trial, again, with gamma delta T cells or whatever therapy, CAR T, I would consider it, especially if the P53 is still present, because we know that clearance is important. If not, again, patients, there are long-term survivors, and allotransplant should still be considered. The one other good thing in cases is we and others have shown that an allele frequency of less than 20 is better than if it's higher, and ideally that will have gone down over time. But I think anything outside of the box to help eliminate it is consideration, but not always possible because we're kind of still in our infancy.
Thank you, Dr. Sallman. The next question comes from James. He would like help with what specific questions should he ask his hematologist oncologist if CAR T cell therapy should be considered for his MDS?
I mean, I think the broader question is ideally, if at all possible, patients get an evaluation at an academic center that has clinical trials. Now, CAR T is not done everywhere. Actually, for MDS specifically, probably quite a limited number of centers. So, for example, we've had patients from all over the country, come for like an evaluation. Of course, there are, if any time a patient can be close to home, that's always best from my perspective. And again, we're super early. The number of patients with MDS treated with CAR T is extremely limited. It's probably less than 20 across the world, across all studies. So, but I think the bigger question is there a clinical trial? So first, before you get any new treatment, I think it's always a good, consideration. Now, many of my patients, which are predominantly Southeast US, they ultimately get treated locally. I mean, there's great, local oncologists who can manage these patients and keep them close to home with all those convenience factors, but we do it together because there's a lot of nuances, especially with, patients, if you're thinking about cure or transplant or targeted therapy. But, for example, if you get 1 day of Vidase or Dacogen, you're no longer eligible for a clinical trial, at least for the first treatment. And so that's why I think every new step, it should always be a consideration. Obviously, if logistically it's impossible, that's the case. But for right now, for MDS, you would have to travel, to a center that has a potential clinical trial. I do think there's going to be more and more over the coming, let's say, 2-3 years. Clinicaltrials.gov, you reach out to, experts, that are involved in this type of research who can help give you answers as well.
Thank you, Dr. Sallman. The next question comes from a patient with the DDX41 mutation, and they want to know, where are we at with this mutation in CAR T therapy?
I mean, so I think we've covered as far as, there's really nothing specific for any mutation right now in CAR T. We're just not there outside of maybe, again, P53 just being a challenging group from their own immune cells. DDX41, which we just didn't have time to get into, is a very interesting mutation. It's one of the more common familial mutations, and it was really discovered, more recently over this past, decade. In that it's very unique in that patients can have it their whole life, right? Because you're born with it if it's familial, but they present late in life with their disease. So you think most inherited or familial, I didn't get it when I was 20, but this could actually present 50s, 60s, 70s, 80s. And what is thought to happen is you're born with one and you get a second one. That's at least been reported in a lot of it. There can be potentially other cancers. So again, patients should often get genetic screening, counseling for family members, and probably some sort of blood count monitoring. But I think anybody that has it, I think there should be counseling, but nothing specific for CAR T and DDX41, at least that I'm aware of.
Thank you. The next question comes from Connie, and she wants to know, is getting older the main cause for getting MDS? She's asked people why she has it. She doesn't smoke, and she's tried to lead a healthy lifestyle with exercise.
Yep. So this is, I get this every single day. Age is risk factor 1, 2, 3, 4, and 5. And again, I always caveat that it's not necessarily just age. It's probably our cumulative life exposures, whatever they may be. But age is the risk factor. So less than 50, it's extremely rare to have MDS, and then each decade of life it kind of goes up exponentially. And so it's tied in with the mutations. Again, we talked about 10 to 15% of people walking on Earth having the same mutations that are involved in MDS. Now, for whatever it's worth, only 1% of those people per year actually get some sort of blood cancer, and it's not always MDS, but it's really age. Nothing else other than a past history of chemotherapy or radiation has been definitively proven. There may be certain exposures like heavy benzene exposures and things, some military exposures that may also be correlated, but it's really age unless you've had past chemo or radiation. Again, with the caveat that some of that is probably tied into life exposures as well. But unfortunately, this is kind of more into the bad luck category. I always talk about bad habits, bad genes, bad luck. It's sort of, more in the bad luck category.
Thank you. The next question comes from Siobhan. Her husband was diagnosed 6 months ago with high-risk MDS with excess blast 1. He's 63 years old, and her question is it normal for CAR T therapy to follow a failed stem cell transplant, or can it be an alternative therapy instead of stem cell transplant?
Yeah, so of course, the pipe dream, and this is actually for CAR T, period, is that we can remove the need for transplant. We can cure patients without transplant. And transplant has a whole host of, bad things that can happen, 20% chance of dying over the, first 6 months, sometimes higher than that based on other risk factors. You have to live typically near the center for 100 days. It's a huge sacrifice. It's as big of a treatment decision as that comes, I think, in all of medicine. And we would love to not need that. But we are light years, not light years, that would be an exaggeration, but I would say we are at minimum a decade, if not longer, from potentially, even thinking about, replacing it. So right now, it's really the goal of getting the best remission possible and going to transplant. As those therapies get better and better, then those questions can be asked. And maybe in lymphoma or myeloma, I think all these therapies have been approved in the very relapse setting, and they're going to get tested earlier and earlier and earlier. And again, that one data, that I showed from the ALL trial was, if you had less than 5% lymphoblast and you got the CD19 CAR, those patients appeared to have been cured. So I think those are extremely great questions to ask where you have a CAR that works very well. In our space, we first have to prove it works, and remissions have overall been short, and you never want to not offer a potentially life-saving and curative option. So we're unfortunately very, very long-term away, but that is one of the real goals of why we're looking at these type of treatments.
Thank you, Dr. Sallman. The next question comes from a patient who has intermediate 1 risk MDS, who is transfusion dependent every 2 weeks and has failed Vidaza therapy and is not eligible for other treatments. The patient is in good shape, 75 years old, young, and how does one decide the risk level of continuing maintenance or moving on to considering stem cell transplant?
Yeah, great, really, really great question. And when I talk with my patients, I'd say particularly, over the age of even 65, definitely over 70, I think it's a very, very personalized decision. And so I think one thing that this case highlights is, intermediate 1 technically being lower risk. So, although in general for lower risk patients, we defer transplant, and that's been proven in some past trials, meaning that if you're high risk, it's better to go to transplant early, but if it's low risk, it's better to delay transplant. But once you've gone through a hypomethylating agent, there's no other standard of care therapy, as this person's mentioned. And actually, when a prognosis perspective, we know that once a patient fails azacitidine or decitabine, that the long-term outcomes are much shorter, even if you're still lower risk. And so I think the options, of course, are always trial. That should be a consideration. And then you have that discussion. I mean, transplant can be curative. And then it's a balance. I think, it depends on how a quality of life is a patient. We have a lot of personal discussion. So if somebody says, I'm happy if I'm alive for 12 months and I'm feeling great, and I don't want to go through all this crazy stuff, not that it's crazy, but then that's option. If somebody says, well, my goal, I'm gonna be alive 5 years from now. I have all these things that matters to me more than anything else, and I'm okay with a lot more upfront risk. Then they've already decided, what they want. At 75, it's a very A lot of things have to go into it. Again, obviously, a patient has to be overall very fit. Lots of stuff has to be worked up. You have to have a good donor option. You wouldn't go with a bad donor option in that setting. But we've had patients, even my own patient, I've had up to 78. So we don't use age as a barrier. For lower risk, where even more, there have to be strong reasons. Maybe patients very heavily transfusion dependent, other issues, but it's a case by case discussion that's important to have with the transplant group.
Thank you, Dr. Sallman. The next question comes from Mojtaba. He is the caregiver for his wife, who's 67 years old with low risk MDS, also has severe bone marrow fibrosis and the JAK2 mutation since 2019. She's stable with a hemoglobin of 10. However, she's lost 10 pounds over a year and has an enlarged spleen on CT of 4 cm, but not palpable. She was offered anti-JAK2, but she is very concerned about the side effects. Her platelets and white blood cell counts are normal. However, her ferritin has tripled, and he wants to know if you have any suggestions.
Yeah, so I think questions that this brings up. There's of course we don't have time to go over all diseases, but there's a lot of patients that can be on a spectrum. So MDS with fibrosis is something that happens, is always more challenging. But there's overlap syndromes, what we call MDS MPN unclassifiable, because a lot of the fibrosis, big spleen, is much more common in patients that have primary myelofibrosis. JAK2 is much more common in patients that either have an MPN or an MDS MPN, more so than with MDS, much rare. So I think that's always a discussion point in, really going into detail about what the patient has. But in these settings, MDS fibrosis, overlap syndrome, if patients are having weight loss and splenomegaly, ruxolitinib, and other JAK2 inhibitors, fedratinib being the other one that's approved right now, can make patients symptomatically feel much better. So for example, we've had a clinical trial and we've published the phase 1 data with ruxolitinib in CMML patients. So that's an overlap disease, chronic myelomonocytic leukemia, where patients can often have the big spleen and the weight loss and night sweats and those sort of symptoms, and have had a lot of benefit there. So I think the sole goal in a lot of these cases is symptomatic benefit. And some of these, obviously if it's not primary myelofibrosis or a specific MPN, they're off label, but there's data out there to support benefit. My overall view on JAK inhibitors is they're overall very well tolerated. I think this brings up, you got to be cautious with reading a package insert and you see all these crazy things. You got to remember that, anything that happens on a trial, and that's mostly what I do, gets reported as an adverse event. So, I use it, if you're bit by a shark, does the drug cause, shark attack? Probably not. But it's reported. I think the challenge with JAK inhibitors is that if a patient has really low blood counts, so, especially really low platelets, for less than 50, kind of ruxolitinib overall is, contraindicated. There are other ones that are being looked at in this space, for example, pacritinib, that may be beneficial in that setting. The other one is anemia. So if you're really low hemoglobin already, all JAK inhibitors will cause it to go lower. Now, a lot of times we can choose the right dose, we can modify it over time, make it to where it's tolerable. And then there are other ones like momelotinib, which is in trial right now, that may help from an anemia perspective as well. But it's symptomatic. If there's more than one issue going along, especially severely low blood counts, it can be challenging. But there are definitely therapies that can be considered given lack of any alternative, and really the goal of symptomatic benefit.
Thank you, Dr. Sallman. The next question is from Michael. Are there proactive things that patients and their families can do to minimize MDS symptoms, such as acupuncture, special diet, particular kinds of exercise?
Yeah, so I think, I'm always supportive of alternative therapies that can help my patients. The big thing I talk about with all of them, and it's really regardless of where we're at, is the healthier my patient is, the better that they're going to do. So even if they don't need treatment, the healthier they are when they need treatment, the better. If they're getting a high-risk treatment, we're going to take them to transplant. It's even more critical. And so, to me, the biggest things are exercise, no question. At minimum, a lot of walking and pushing themselves. A lot of patients, maybe as they get older, they've done less and less. and maybe they've gotten anemic and they've had this sort of downward spiral, and we got to turn that around. And so, I have patients, maybe they're making multiple just loops in their house, and then the next day they do one extra loop, and then they start walking outside. Of course, we have the Florida heat, at least where I am, but every day they do a little bit more. So it's extremely important, and whatever they can find that works well for them is great. If it needs to be non-weight bearing, if it's swimming, it's stationary bike, but the more they do, the better. And what can't happen is, oh, I'm so tired, I can't do anything. If that happens, patients do very, very poorly. And that can be a hard push in the beginning, need a lot of family support, but that's sometimes a make it or break it for even considering, therapies. Most patients can be, considered for, hypomethylating agent, or of course, a lot of the lower risk therapies. But, if you want to be considered for a trial, you have to have a certain performance status. If it's not there, it's not an option. As far as, things like special diets, the biggest thing for me is just good protein intake. People need to keep their muscle, their body's somewhat in a catabolic state, keeping, calories overall, and sometimes calories, even if they're bad calories, I'm okay with. Sugar does not feed cancer in this sort of setting or anything like that. And I won't argue about some of that stuff, but the key is calories, and more than that, protein. And then sometimes, people go on super alternative restrictive diets, and, you have a 90-year-old patient and he's ate a certain way his whole life. He's not going to change, and changing it may hurt him. And so you want to be cautious, with that. But high protein, eating when they're not hungry, protein supplementation, like, of course, you can have Boost and Sure, or you can go to any wellness store, and there's tons. The more calories, the better. Get that in between meals. Maybe you have to add ice cream, peanut butter, other things like that. But keeping their weight up, keeping them active is really key. I think the other stuff, if something makes my patient feel better, great. As long as it's not a drug or chemical that I don't know anything about, and we have no idea about interactions, in general, I'm supportive. Of course, based on your blood work, you would have to potentially discuss, acupuncture or massage. Like, you just let them know there's a lot of alternatives, to that, and some that have specialized in that type of medicine in patients that have had blood cancers. But if it makes my patient feel better, great.
Thank you. The next question is a 50% related stem cell donor considered a bad donor if the patient has antibodies against them?
Yeah, so a 50% donor is almost always what is a haplotransplant. So this is typically a transplant from a patient's son, daughter, granddaughter, something, can sometimes be siblings and other things like that. But that's why it's a half match. And it's kind of complicated and confusing how it works. So a half match, for example, if somebody has a true mismatch, which is usually, a 7 out of 8, or double mismatch 6 out of 8, or you'll hear 9 out of 10, or that sort of thing. That's actually a very high risk transplant, because graft versus host disease is a real issue. The haplotransplant, and this some of this was emerged out of Johns Hopkins, where they often will give a drug called cyclophosphamide after transplant. And what happens is that when there's this half mismatch, the body recognizes it and kind of revs up these T cells because they're very angry. And then actually you give this drug, it kills those bad T cells and the good ones hang out. And for what it's worth, with haplotransplant from a safety perspective, have had lower rates of graft versus host disease. So it may actually be a safer transplant. There's a little bit of trade-off in that the killing, or the curing of a disease, so what we call graft. So graft versus leukemia is good. Graft versus host bad. There may be a little bit less of that. So you get maybe a little bit less killing, a little bit safer, but thus far, and some of this work is still ongoing in large transplant trials, haplotransplant has seemed to do as well as even matched transplants, and is by far our preferred transplant. So for example, at our center, we don't use a cord blood transplant almost ever. And really haplo would be, of course, if you have a sibling or an unrelated donor, that will often be an option. But if not, a lot of patients get haplo options. There's a lot of ethnicities where the chance of having a perfect match is less likely. And thus we do consider haplotransplant. The antibody question, it's a little complicated. That's probably a more one-on-one with your doctors. I think the only patients that ultimately don't have donors, and this is not just for haplo, but can be. I mean, a lot of times is that if a patient makes antibodies to all their family members, so to their brothers, sisters, daughters, then they run a risk of rejecting the graft. And that's independent of it being a half match or not a half match. And then that's my rare patient. I probably get 1 or 2 a year that can't go to transplant because of that. But it depends on it. That really requires very expertise, transplant consultation, and you would need to discuss that with them.
Thank you, Dr. Sallman. We have time for just one more question, unfortunately. This question is from Joe, who has low-risk MDS, watch and wait, diagnosed in June of 2021. He has a hemoglobin of 10.2, hematocrit of 2.84, occasional alcohol, and he wants to know if he should cut drinking alcohol entirely, or will an occasional drink not hurt him?
Yeah, it's a really good question. I do get this question all the time. I think the one thing nicely that this case highlights, right, is there is a subset of low risk disease that, and again, and I even have rare high risk patients. So, I actually have one lady, and this is, she's been 15 years never treated, and she's had increased blast, but her blood counts were beautiful and normal. So again, a lot of patients, especially, if they're low risk, no question, but even rarely in other settings, can be watched. And ideally, if I can never treat a patient, that's the best. I think the alcohol thing is a great question. I mean, if somebody has bona fide MDS, the cause of their, and this is, some of my personal opinion, the cause of their MDS is they have a abnormal factory from these cancer cells, and the factory's not making cells as they should. And so, an occasional drink of a glass of wine or liquor or whatever, to me, is not going to make that worse at all. And I don't have any issue of that with my patients. You do get differing opinions. Now, I think if somebody has a heavier alcohol history, where there may be some toxic exposure, to the marrow, clearly trying to completely have all cessation for months and see what happens. I've had a couple of people who've had major count improvement. But if this is sort of a social, thing, over their life and really hasn't changed, and people can always try it for a while, and it never does anything. And to me, my personal opinion is quality of life is very important, and that this is important for some patients' quality of life. And so I don't think it does. But of course, you need to discuss that with your physician, because there are differing opinions on that. But that is my personal opinion.
Thank you so much. And thank you. That's all the time that we have for questions. Thank you, Dr. Sallman, for participating and for your time and overview and effort that went into preparing for this webinar. And thank you all for attending today and for your great questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. And if you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with the link within 10 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.
Thank you.